what's going to happen if a person is having a hypertensive intracerebral hemorrhage, and usually it's the smaller blood vessels which would be affected here. The usual diameter would be in the range of 30 to 100 micrometers. So hypertensive intracerebral hemorrhage primarily occurs because of rupture of perforators, or I can just say small penetrating branches. Most of the time the question will say which areas the bleed can occur. I mean, due to hypertension, the bleed can occur in any area of the brain, but there are certain areas which are relatively predisposed. So rupture of a small penetrating artery, one that can be involved is the basal ganglia. Right from your undergraduation days, you've done this standard MCQ, hemorrhagic stroke in a hypertensive patient, what is the usual site of bleeding? Your answer would be putamen. Apart from putamen, the person could also be having a bleed in the thalamus, and if there's a thalamic bleed, then the high probability of involvement of internal capsule will also be there, and therefore capsule involvement can explain the development of hemiparesis in this patient. Face, arm, leg weakness can occur. And apart from putamen, thalamus, other sites where the bleed could be occurring is cerebellum and pons. If the bleed is located inferiorly, then the chances of deterioration of the patient will be relatively higher. I mean, I said any bleed is bad, but infratentorial bleeds will have a faster chances of deterioration because of the precarious location and chances of obstruction of the vital centers in the brain, plus causing a sudden onset increase in intracranial pressure in the patient. There is also possibility that this bleed can have a IVH extension. If a question says what is the leading cause of intraventricular hemorrhage, like in pediatrics, in your UG days, you read about intraventricular hemorrhage seen with birth trauma, faulty forceps application, whereas leading cause of intraventricular hemorrhage in an adult patient can be an extension of an intracerebral bleed. I mean, I'll repeat that again. Intraventricular extension is possible. Usual reason why a intraventricular hemorrhage can occur in adults, though we can have less common causes also like polyarteritis nodosa. Even in SLE or lupus, we do have possibility of intraventricular hemorrhage. I mean, trauma is obviously understandable. I said polyarteritis nodosa, lupus are important causes. But overall, if you look at it, then intraventricular extension, if it's occurring in a person, then it is an extension of a intracerebral bleed due to hypertension. Now, what is the bad news about intraventricular hemorrhage occurring concomitantly and an intraventricular extension occurring in a person? Then the bad news about concomitant intraventricular hemorrhage or an intraventricular extension is that the person will have higher chances of development of a raised ICP and even chances of development of hydrocephalus. The main message is that hypertensive bleed would affect the small penetrating blood vessels. Putamen is the number one site, then thalamus, cerebellum, pons, and chances of deterioration in the patient would be relatively higher. In most of the cases, if it is hypertension, the bleed tends to evolve over a duration of 30 to 90 minutes. So this gentleman, let me say, is retired from the army, has had good physical health, who has been hypertensive, and he goes for his morning walk every day. So today morning he got up, he put up his sport shoes. Maybe his wife made him a cup of tea or coffee as well. So this guy was doing fine, at maybe 5:36 in the morning, and then he was planning to go out for yoga or for a routine morning walk. And his wife saw that he was still sitting on the sofa, and she asked him casually, "Are you fine?" And when she looked in his direction, she noticed that his face was looking funny. So initially she thought that maybe the old man is playing a prank. The wife is thinking husband is playing a prank. She said, "I mean, your face looks funny. Are you fine?" So you will notice that initially in these patients, I mean, the description given by the family members will mainly be in the form of a facial sag. And then subsequently, I mean, there would be an arm weakness developing in a person contralateral to obviously the side of bleed. There would be arm weakness developing, and then there could be, most of the time, the presentation would be a facial sag and an arm weakness. And then in some cases, like if the internal capsule is getting involved, leg weakness can also occur, and speech deficits can also occur in a person. I mean, aphasia can develop in these patients. If the dominant side is affected, non-dominant, then it is apraxia manifestations. In contrast, when it comes to a coagulopathy, I've already said that coagulopathy will even be more dangerous, though you have chances of reversal of the coagulopathy. But most of the time, I mean, it can be life-threatening to the level that person may never reach the hospital. The raised ICP can be so bad that, or the magnitude of raised ICP can be so severe that by the time patient reaches the hospital, it's too late, and you might get a patient with posturing and might subsequently expire or might become brain death. the evolution of bleed, the basic point is bleeding with respect to hypertension usually was for 30 to 90 minutes with a coagulopathy over the duration that I mentioned.